So let us talk about and learn about pancreatic necrosis management in the setting of acute pancreatitis. I'm grateful to my mentor, Dr. John Stroline, Mr. Charles Butt, Ms. Angela Deal, my institution, and my mentors. Please read this notice. So you have taken over the service from your colleague, and when you round on this patient who was admitted on July 5th with necrotizing pancreatitis, and he had mild organ failure, uh, respiratory failure, renal failure, but he has recovered with excellent management by your team. Unfortunately, he was not able to get enteral nutrition because of ongoing ileus and unable to tolerate enteral feeds. So that's why he continues to be on TPN. Ideally, you want to have it delivered through the enteral route. So today is July 15th, 10 days from his admission with acute pancreatitis, and your staff as well as the patient's attendant and the family report that this gentleman had a rough night with a lot of pain during the night. And then when you go to the bedside and you watch the monitor, you're worried looking at his tachycardia, pressure that has dropped, and oxygen saturation has dropped, and he also is febrile with a temperature of 39 degrees centigrade. In this setting, you worry about possible infection in the setting of acute necrotizing pancreatitis. The infection could be in the chest, in the IV lines, in the urinary tract, and in the bloodstream, as well as in the pancreas. So you do the infection workup with a chest X-ray, urine exam, blood cultures, etc. And you also have to make sure that the patient doesn't have infected pancreatic necrosis. While you're trying to arrange the CAT scan, you request your team to start him on broad spectrum pancreas penetrating antibiotics once you've drawn the cultures and done the basic workup as quickly as possible. And before you go down to look at the CT scan, you look at the admission CT. Obviously, you notice that there is quite extensive pancreatitis with necrosis as well as necrotic fluid collections. And when the CT scan comes back, what you notice is some pockets of hair in the infected pancreas, obviously gas, and that is a sign of infected pancreatic necrosis. In the absence of any gas, when the patient has no other source of infection, you should consider that the patient has developed infected pancreatic necrosis. In the past, we used to send the patients for emergency CT guided aspiration of the fluid to look for infection, but now most experts are basically treating them with a presumptive diagnosis of infected pancreatic necrosis with broad spectrum IV antibiotics that penetrate into the pancreatic necrosis. While you're doing that, you also manage the patient in terms of his nutrition, and whenever his bowel sounds return, you want to change it to enteral nutrition. So medical management with broad spectrum antibiotics and general supportive care can manage most of these patients with infected pancreatic necrosis uh, to the point of taking care of this infection, as long as the patient does not deteriorate. And you want to continue the antibiotics and wait until the necrosis becomes walled off pancreatic necrosis with a well-defined wall. You don't want to intervene prior to this because it is much more complicated. So, as you can see here, this is almost 4 weeks from the admission. The patient has been on antibiotics for at least a very long time since the diagnosis of infected pancreatic necrosis was made. And you feel happy that the pain has resolved. In this setting, you manage the patient medically by observing, and as long as he's able to eat and keep his nutritional intake in and is not in pain and does not develop any other side setbacks, you can manage this pancreatic necrosis medically for the body to take care of it. On the other hand, by 4 weeks period, the pain is still persisting, and in that case, you have to consider some form of treatment. So, how do you treat pancreatic necrosis with or without infection that has been walled off? So, important to wait for 4 to 6 weeks after pancreatic necrosis before you intervene. So, when it comes to walled off necrosis, debridement, most important thing is you wait first for at least 4 to 6 weeks for the things to settle down and have a walled off necrosis. You could either consider internal endoscopic drainage or external uh, interventional radiology directed drainage. Uh, External drainage by putting a catheter under ultrasound or CT guidance into the pancreatic fluid collection, especially if it is laterally located with necrosis, it will help. And once you drain the fluid, and then if there is necrosis, through this tract, percutaneous tract, one can do necrosectomy or removal of the dead pancreas tissue. Another option that is now very widely used is endoscopic drainage with the placement of plastic stents, especially if there is a lot of liquid necrosis that can be drained easily through this cystogastrostomy type of procedure. So where you use an endoscopic ultrasound and an ultrasound guidance, you puncture the fluid collection and dilate the tract through the stomach wall, and over guide wires you deploy a couple of double pigtail plastic stents. If there is a lot of necrosis but it is walled off and not much of fluid, in that case nowadays most therapeutic endoscopy centers are trying to lean on towards placing a metal stent. It is called lumen opposing metal stent or LAMS, and this helps the endoscopists have access through the bigger bore stent to go through the stomach into the necrotic cavity and do debridement like any other wound debridement. So this is what it takes for management of pancreatic necrosis. Most important in pancreatic necrosis is maintain nutrition as much as possible to the enteral route, and be on the lookout for infection which can develop in the week after 10 to 14 days. And if it happens, broad spectrum pancreas penetrating antibiotics, and carefully watch as long as the patient does not deteriorate. No need for surgery. and wait for at least 4 to 6 weeks for the necrotic collection to get walled off. And once it gets walled off, if the patient is asymptomatic and able to eat and no pain, you can continue to monitor. On the other hand, if there is pain and patient is struggling to eat and all those things, then you could consider either external drainage using interventional radiology colleagues, or internal drainage with the placement of either plastic double pigtail stents or a metal stent for fluid drainage as well as necrosectomy. I hope this is helpful. Thank you.